There we go. So by staying on, you are consenting to be recorded. Next. Please everybody mute your microphones and then unmute if you wish to speak. We do have the emojis and the raising hand highlighted, so you can use that if you need to. If you would like to speak or ask a question, please. This is the more interactive, the better. Next slide. If you're having issues with your name, we've noticed that quite a few people sign in and they come up as Catherine. You can rename yourself clicking the 3 buttons up at the top. Next. Please do not discuss any patient information if you do ask questions or you have other patients you want to discuss. Make sure that you do not violate HIPAA laws. No patient identifiers, please. Next. We are funded by HRSA and an EMS grant. I have no commercial interests, neither does Dr. Bullard-Barrett or Dr. Music or Jeff. Okay, next, please. All right, so pediatric considerations. I have to say that pediatric orthopedics is our bread and butter in the pediatric emergency room. They definitely keep us busy. Which is a good thing. Yes, Catherine?
I just want to ask everybody, we needed some introductions here this morning.
Oh, sorry.
And if we're going to introduce our faculty members who are assisting with the project and our guest speaker or case presenter. And then for our community members, we are so grateful that you guys are able to participate, and there are so many of you, but if you would be so kind and enter your name and your agency and your role, or just your name and your role into the chat box. We would just like to try and open up that community perspective for everybody to connect through our ECHO program. And again, thank you. I'm sorry, Dr. Dakin, please continue.
So Catherine, would you like to introduce yourself? And I'll go through people. I'm sorry.
Thank you. I'm Catherine Schaefer, and I'm the program manager for Child Ready ECHO. And again, thank you so much for being here this morning. It is truly our privilege to serve you.
And Dr. Bullard-Barrett. He's vanished. Dr. Music.
Hi, I'm Dr. Music. At Gallup Indian Medical Center, and I'm a trauma surgical critical care surgeon, and I've been here since 2011, so it's been 10 years.
And Dr. Sapien.
Welcome all, I'm Robert Sapien. I work at the university with Catherine, Sarah, and Jeff.
Okay, so that is today's main panel, and then of course all you lovely people. So please, like Catherine asked, put your name and where you're from in the chat, and I look forward to having some lively conversation over orthopedic injuries. Okay, next slide, Catherine, please. So our objectives are really around the ability to identify these pediatric specific injuries, and then helping you guys decide whether patients require emergent orthopedic interventions or can have delayed orthopedic consult after being stabilized in either rural or outlying communities. We'll run through a few pathophysiology of some bone development, and then get into the meat and bones, as it were, of pediatric orthopedic injuries. Next slide. Sorry. So pediatric orthopedic injuries impact multiple factors. Pediatrics have those bendy bones. you also have how pediatric patients interact with their world and the injuries that they sustain. You know, they have young, healthy bones versus, I hate to say this, you or I with their older bones that do not heal as well. Don't we all wish for those lovely bendy bones when we fall these days? So next slide, please. So how are they different? Pediatrics have a very thick periosteum that protects the bones and allows some bending. And along with that and their high percentage of cartilage means that they're much more elastic. The open growth plates support faster growth and healing. That can be a positive and a negative. You know, they heal faster, but if the growth plate is damaged, it can impact the growth of that bone. Next slide, please. Another negative impact is that in pediatrics, the ligaments are stronger than the bone, whereas in adults, it is the opposite of that. So often during injury, the ligament pulls away from the bone, damaging the weaker pediatric bone versus the adult bone. Next slide. So adults and pediatrics both have Haversian canals. Sorry, trip over that word. But in children, because they're more condensed in relation to the size of the bone, they make the bone more porous. But on the positive, they can act as like a stop in a fracture. If you think of your car window, as the crack comes along and you're trying to stop it, they drill that little hole to stop the crack coming completely across. So it does actually have a positive and a negative, making it bendy and porous versus also stopping those cracks going all the way through. Next slide. And then, of course, how pediatric patients interact with their world. You know, they're jumping, swinging, and living crazy, imaginative, fun-filled lives. I mean, who doesn't want to be Batman or Spider-Man when you're little? But the major fact is that their life experiences, they don't know how to interact with the world. If you or I have something coming at us, we tend to move away or, you know, turn to protect ourselves, whereas pediatric patient will turn into it because, you know, they don't realize it's a car coming at great speed. They just turn to look at it. When they do impact with vehicles and things like that, because the majority of the body mass is below the bumper, especially in smaller children, they tend to go under versus over, impacting the type of injuries that they will sustain. But not so far. Thank you. We are going to run through a few pediatric specific fractures that are listed here. Next slide, please. So a green stick is very pediatric specific because of those bendy bones and that thick periosteum. As you can see, the bone is still attached on one side, yet broken on the other. It's called a green stick injury because it is exactly like a green stick. When you try and break it, it doesn't snap cleanly. It just kind of opens up. This type of break is, of course, going to need some kind of sedation or surgery, and often they have to complete the break to be able to get those ends back into some kind of realignment to facilitate healing. Next slide, please. A buckle or torus fracture. This one can happen in older people, but not as frequently. Often the wrists, as they fall on the outstretched hand, the bone is kind of compressed into each other. And this is more of an axial load injury. These arrows, you can see that slight bulging, that's where the bone has been compressed. This one remodels very nicely, just needs a little splinting and then later casting after swelling. will of course need orthopedic follow-up, but does not necessarily need sedation and realignment. So as you can see, the different axial forces versus bending forces will definitely impact the type of orthopedic injury these patients sustain. So think about that when you're asking the history of the injury. Will give you an indication of what type of damage you're going to be looking for. Next slide, please. And then growth plate injuries, of course, this is purely pediatric because as we get older, our growth plates close. The concern for pediatric fractures is that the growth plates are damaged. And if there's damage such as in type 2 or 3, the bone usually continues to grow. There may be slight difference in length, but they manage to mold and grow fairly well. Unfortunately, once you get to a type 5, the growth plate is damaged the full way across, and this often impedes the bone growth on that limb. So you'll end up with a shortened limb. Hang on. Jeff, is Jeff still on? I know he had a comment he wanted to make about this one.
Yep, I am here.
Oh.
I'll go ahead and post it into the chat, but I've always found that this Salter, S-A-L-T-E-R, is really confusing and hard for me to remember because I never know what's above and what's below. And so the quick, easier mnemonic I think to remember is when you come to Salter-Harris fractures, remember there were always fractures of the physis. And then the question is, what part? It's the physis, and is it the physis and the metaphysis, or the physis and the epiphysis, or both? So type 1s are easy because they're make-believe. You don't see anything on x-ray. Type 5 is kind of easy because it's just a crush. It's the 2, 3, and 4 that are tough. So if you just think of me, you'll never forget. So just remember the acronym ME. So a Salter-Harris type 2 is the physis and the metaphysis, the first M. A Salter-Harris type 3 is the physis and the epiphysis. And the type 4 is the physis and both the metaphysis and epiphysis. So if you just think of me, you'll never forget.
Thank you. Next slide, please. And then, of course, there is the toddler fracture. This is a spiral fracture, and people often are concerned with spiral fractures for non-accidental trauma or abuse. The toddler fracture is very specific to the mobile. So from 18 months to about 6 years of age. These toddlers have been running around doing something, and the history usually comes that they were climbing on something or bouncing on something. And as they trip, they catch their foot in something. So as they fall, it twists and the tibia has a spiral fracture. Now, that being said, if there isn't a history or a story congruent with the injury, then there should be concern for non-accidental trauma. But in this age group, it is more frequently that toddlers fracture as they twist and fall, which is rarely non-accidental. However, any spiral fracture, especially in the non-mobile infant, should be raise concerns for abuse. Thank you. And then, of course, supracondylar fractures. These really are our bread and butter because it's the monkey bars, the bunk beds, the bikes, and the scooters. This injury often happens as the child kind of falls back from, the monkey bars and lands on their elbow. And basically, it breaks at the weakest, narrowest point just above the elbow. Next slide, please. So I think this one's pretty obvious. It's pretty broken. You definitely want to require splinting and emergent ortho consult if you saw this, ensuring that the patient's sensation, movement, and pulses are intact and pain med has been taken care of. And if you look closely, you can see that this fracture is almost open. I mean, it was like literally like a millimeter. And quite often with these injuries, because of that impact, it does break the skin, which of course raises the concern for infection as well. Next slide, please. Because this is such a common fracture, I am going to run through a few care management. So stabilizing this fracture with a splint, making sure that there is room for swelling. This would be suitable for emergent transfer for orthopedic consult if an orthopedic consult was not available in your community. Make sure that the patient is NPO, of course, because there's a possibility they're going to need to go to the OR. And an EMS transport so that then pain management can be taken care of. You know, this is a big issue, especially in New Mexico, because we have such distances to travel to a tertiary care center. Next slide. Now this is also a supracondylar injury, but a little more subtle. The similar mechanism, but not as impressive findings. Next slide, please. And there are two signs that indicate that there's a possible fracture. A sale sign, the anterior fat pad, that little dark area that I've highlighted. Next slide. The fat pad shows joint effusion and possible fractures. Next slide, please. Whereas the posterior fat pad, which is on the opposite side of the bone and is that small dark line, I couldn't highlight it without completely obliterating it, really does frequently indicate an occult fracture in pediatric patients. Because their bendy bones remain in place, you can't see the fracture, but that swelling and fat pad sign is often an indication that there is an occult fracture, and this should be treated as if it is broken. Next slide, please. So splinting, pain management, and then an orthopedic consult. This is not a patient that would need to be emergently transferred, but getting them hooked in with orthopedics sooner rather than later for further evaluation would be great. Next slide. This one would be a good one for both pharmacological and non-pharmacological pain management. So making sure that the parents understand to continue to give Tylenol, Motrin for pain management if needed, something stronger if they feel that the pain is that extreme. Making sure families are aware to, keep the arm elevated to the level of the heart, and short periods of ice, making sure that families are aware not to leave it on for long periods of time so that we don't end up with frostbite adding to the complications of a fracture. Sorry. Next slide, please. So one of the things we see occasionally is families that have not monitored the fingertips. So especially if they're not receiving immediate follow-up, educating families on how to keep an eye on the child's fingers, making sure that they remain pink, that they can still move them, that they're not having any pain or numbness in those fingers. Next, please. So the 5 Ps of orthopedic injury would be the pain. So making sure that these patients are given adequate pain management, educating the families on keeping an eye, like I said, on the fingers for numbness, the ability to move, and do they still blanch and pink up. So, you know, 5 minutes of educating the families will make a big difference in their long-term outcomes, especially if they can identify if the splint or cast is getting too tight and how to then receive care.
Hey, Sarah, can I interject for a minute?
Yep.
Could we go back to the really ugly slide of the supracondylar fracture for a minute? And just for, you know, our people out at our more remote sites, you know, these are the kind of, keep going.
Catherine, the next one. You haven't gone far enough back yet. There.
That one. So, you know, when you see fractures like this and you know that this is something that's going to require operative management, if the arm is not pulseless, these aren't ones that you need to try to reduce before you send. Of course, you know, if the arm is pulseless, if there is bone sticking out through the skin, it's, you know, an obviously open fracture. Yes, then a gentle reduction and splinting in place. But these aren't the ones to spend a lot of time trying to get lined up again to look cool when you send them to us. Our orthopedists kind of try to convince us not to mess with the real obvious surgical ones until they get them to the OR. You know, obviously it can get a lot worse if you're pulling on something, and, you know, there are kind of some important arterial structures right there as well. So these are ones where, unless they're pulseless, don't really try to reduce them. These are ones to just splint as they are and send.
Thank
Sorry
you.
about that.
Yeah. Thank you, Dr. Goldberg. And Sarah, it's 8:22.
Can you go forward, Catherine, to my? Yeah, too far. There we go. So my take home for this is, as Jeff said, stabilize. That will help a lot with the pain and also reduce any potential damage to the surrounding tissue. Monitor the 5 Ps and educate families on keeping their child NPO, especially if it's an emergent transfer, or even just showing up for a regular orthopedic first appointment. I would recommend them being NPO at least for a couple of hours before that appointment in case some kind of sedation is needed. And then, of course, consulting for orthopedics to see whether they want the patient emergently transferred or can be sent at a more leisurely rate for a follow-up in 24 hours.
We need to review the chat box.
Any questions?
Well, you know, again, in terms of when I'm thinking about which patients need to be transferred versus which patients I can reduce and handle wherever I am, you know, in general, for the forearm fractures, we're looking at less than 15 degrees of angulation of, even if it's a both bones fracture of the radius and ulna, you really don't need to do anything other than splint in place. And in fact, even with the fractures where they're completely fractured and overlying, there's really good research showing that for forearm fractures, even if you splint those in place, yeah, it'll take a year or two for it to mold and be completely straight again. But the truth is, those will heal just as well as a fracture that we reduce immediately. So one, kind of take the heat off yourself. You know, reduction isn't the end all, you know. Yes, sometimes it really does help. And ultimately, yes, it will give you a straighter bone more quickly than a non-reduced allowed to heal by itself. But just really think about, you know, which patients do I really need to transfer? And to me, those are the patients where, obviously, if it's an open fracture, yeah, we really want to see that kid at UNM. If it is one of those type 3 supracondylar fractures where it's obviously displaced or there's any kind of question of vascular injury, those are ones to send emergently to, a level 1 center. But most of the other things, really, you can splint and they can be seen within a week by the orthopedist. They aren't something that needs to be seen immediately.
Thank you.
There was
Oh.
a couple of comments in the chat box from Dr. Sapien and Dr. Torin.
Yeah, Dr. Sapien put in the chat box regarding that posterior fat pad sign versus the anterior. The posterior equals poor. Anytime you see a posterior fat pad, there's always a concern in kids. The anterior fat pad's not so much. Any other comments or questions?
And Catherine, can you go back to that picture of the anterior, or the posterior, I mean, fat pad? So it's just that line that would not be there, indicating some swelling. That's what you're looking for. Thank you.
And just also remember, with kids with growth plates and with fat pad signs and things like that, it can always be a challenge. If in doubt, they have another limb. X-ray the other side and compare. That's kind of, old school, but then again, I'm kind of old. And I think that that's, something that we often over-treat rather than just X-raying the other side and comparing.
Okay, so I at this time would like to introduce Dr. Music. She is coming to us from North
Gallup.
Indian
Gallup.
Medical
I'm
Center.
sorry. She has a case study for us today.
Okay, you can go to the first slide, please. So a patient that I have to present here is a 9-year-old male who at the time on August 7, 2019 presented to the ED after at school he fell sliding down a slide onto his left ankle. He presented with left ankle swelling with ecchymosis over the medial aspect on exam, but no deformity or crepitus, no past medical history, no medical history, no family history. Next slide. He had left tib fib 2 view x-ray done that shows the spiral fracture of the distal left tibia, but no, at the time, no report of a growth plate involvement. He was placed in a left short leg splint and consultation was made to the orthopedic on-call doctor with a plan for follow-up in the clinic on August 9th. Next slide. So the time he presented to the orthopedic clinic, this is not the picture of the kid, but apparently it's a bigger foot. But the orthopedic doctor placed a long leg cast, and then he was told to follow up on August 16 with an ortho PA for an x-ray and a follow-up. Next slide. Next slide again, sorry. So on the 16, he had, when he had a cast placed on the 9th, he had an x-ray done that showed the spiral oblique fracture of tibial shaft with the overriding fracture fragment, but apparently was noted to be healing appropriately. And then he was scheduled for another follow-up with an x-ray on August 23rd. And at that time, the x-ray showed the well-maintained position of the shaft fracture. Next slide. Then the patient was follow up on September 6th, again with a different ortho PA, and a short leg cast was placed at the time On the x-ray that was done prior to removal of the cast, this is the report that you see, the oblique or spiral fracture of the distal half of the diaphysis of the left tibia extending into the distal metaphysis, if not to the epiphyseal plate. No interval change. The knee and ankle joint spaces appear to be properly aligned. The patient was then placed back on a short leg cast. Next slide. Then he came back on September 17 to urgent care clinic, complaining of worsening pain to the left ankle. No provider was able to see the patient. Apparently it was either busy clinic and the patient left prior to being seen by a provider, but he was arranged for a follow-up in the ortho clinic on September 20th and underwent another x-ray that showed unchanged position of the distal tibial diametaphyseal area. The short leg cast was removed to permit examination of the leg at that time in the ortho clinic. He was shown to have a ulceration that was not actively infected, and another short leg cast was replaced on the same day. Next slide. He still was complaining of pain per the caregiver, and came back on October 7 with worsening left ankle pain. And he was sent to the ortho clinic the same day and saw another different orthopedic provider. And at the same time, the cast was removed and a cam walker was placed and the patient was sent home. Prior to that, the x-ray done showed healing of the fracture line. And he was seen with another orthopedic provider on October 17. When he was seen, he had another x-ray done that apparently showed healing of the fracture line, and the cam walker was discontinued. When he was seen on October 17, apparently he had no leg pain on examination, and he was clear of all activity restrictions. Follow-up appointment was made for the patient on November 22nd. So everything was cleared, and he was cleared by orthopedics and has not had another follow-up until he was seen in his regular pediatric follow-up clinic on May 3rd of this year. And per his caregiver, he was reported to have residual limb, not painful, but he was apparently had some discomfort that not by walking, but mainly with physical activity and running, not really having so much pain per mother. But when he was follow up in ortho clinic in May 19, he was noted to have pain on examination over the left medial angle and also with a slight limp. The orthopedic provider, so this is a different one that saw the patient in 2019, review all the films from the previous visit and was concerned that it was a possible Salter-Harris fracture as early as September 19 film, the one that I read the X-ray report. The film from his initial injury did not indicate any Salter-Harris fracture. He had an X-ray done, which I will show next slide, that showed tibial fracture, but there was a concern that the patient had leg length discrepancy. So the patient is being referred now to orthopeds at Carey Tinkley for further assessment and possible treatment with surgery. I believe that's it. That's all I have. And that's the X-ray, the final X-ray that he had prior to the refer to or Carrie Tinkley.
Well, first, thanks, Dr. Musica Sinethorn. We really appreciate you bringing a case forward and presenting. And second, I have to kind of apologize. We tried to have our pediatric orthopedist involved in today's Zoom, but unfortunately there's a resident graduation party apparently going on this early. Difficult to believe, but they all bowed out. But I did get a couple of them to review the case as well. And overall, they really felt that care was appropriate, and neither of them actually were convinced that there was a Salter-Harris fracture that was missed early on. They actually both felt that even if there had been a Salter-Harris fracture early on in the medial ankle, that the treatment was still appropriate. It would have just been casting. It didn't require anything further with it. Sarah, do you remember other points that they brought up?
No, I think the big part was that the care would have been the same either way.
And then, in terms of, this kid developing a blister under the cast, I mean, that is something that, for years and years at UNM, the pediatric orthopedist never allowed us to put any kind of like sugar tong type cast, anything that had, well, they didn't allow us to use web roll circumferentially. That was their big thing. They were always very worried that we would mess it up. And so they always had us just run it linearly along the splinting. Over the years, they finally loosened up on that. But I mean, it's the reminder that, casting and splinting is actually kind of tricky. And especially if patients aren't going to follow up in a timely manner, that's when you really end up having the blister and skin breakdown issues. So really making sure that patients having follow-up is important, and that, padding is a great thing, especially over any kind of bony prominence, but you can also have too much padding when it comes to casting and keeping things reduced in the right way. So it's a fine line. So, make sure that the person who's the most comfortable doing your splinting or casting is the one doing it.
I was going to say the other thing that it makes me more aware of is if they are complaining of pain and there aren't, on x-ray, there aren't any new changes or, bones shifting and the splint look or cast looks appropriate, then maybe it is some kind of skin breakdown and, should be investigated further like you guys did. It makes me very aware that we can have this skin breakdown fairly quickly, and we should be thinking about that if the pain is disproportionate to the injury.
My question is I mean, obviously I don't do peds ortho as being trauma surgeon, but is there common to have so many x-rays on follow-up for pediatrics ortho trauma?
Yeah, I mean, pretty much they would see these kids, with something like this. They would see them initially, they would go ahead and x-ray them, then see them usually at 4 to 6 weeks, re-x-ray them. And, pretty much at each visit, it's kind of like asking a urologist to see a patient without a UA. Asking an orthopedist to see a patient without an x-ray is near impossible, So, yeah, it seems like they did a lot, but it also seemed like his course kind of dragged on. So I understand why they did them. The other thing that I would think about kind of long-term, now a year and a half out, this kid has a limp, is yes, we're focused on that ankle and his original injury, but he's what, like now 10 or 11 years old. So maybe he's got, when I would evaluate him again, I wouldn't be stuck in just looking at his ankle. It's like, could this kid now have developed a slip capital femoral epiphysis? You know, and is that why he now has a chronic limp? So I think I would actually x-ray even more, you know, seeing him now, and probably would get his entire leg. And I suspect that's what Carrie Tingley will do when they see him as well. Just, you know, it's easy to focus in on that ankle because that's where it was. And, you know, this could be one of those lousy situations where he really did develop a leg length discrepancy now. It's a year and a half out. So, you know, this in spite of appropriate care, this could still be a not terrific outcome, you know.
Dr. Jolly has a question about what is the most commonly missed fracture? And the second one.
No, that's the answer. The second fracture is the one that's the most commonly missed.
That was your answer. Sorry, sir.
Yeah, you see the first one and you stop. So that's what I was trying to nail home Jeff's point that yeah, you're focused on this one location, and you may miss the second location.
At this point, if any of the community members have any questions or anything further to discuss, please feel free to sign it into the chat or unmute yourselves.
Dr. Music, I'm presuming that patient had to travel up to Albuquerque for each of those orthopedic visits. Do you think that all of those trips financially or otherwise impacted the family? Oh no, she froze.
Actually, I think those were all seen in their clinic.
Oh, nice.
Yeah, I'm sorry, I kind of like got cut
Yeah.
off for some
Yeah.
reason. Yeah, they were all seen in our ortho clinic.
Oh, that's nice, because the travel time would be quite detrimental, and especially with your fracture hanging over your car seat. I was thinking of the swelling as well as the financial impact of those car journeys
Right.
backwards and forwards.
The Carrie Tingley one from now on, that would be a
Okay.
different story.
Yeah.
And just a quick question. I don't know what virtual physical therapy is like. I guess they tell the caregiver to do certain moves and on video.
So from what I understand, it is similar to this kind of platform, and they have the caregiver work through a number of exercises with them, ensure they know how to do them correctly, and then the family is responsible for continuing the physical therapy after they've been shown how to do the exercises. And I think especially with pediatrics, it can be hard to get them to maintain the regime that is expected versus, you know, if you go into the office 3 times a week, a video call once a week and being shown them probably is not quite as effective, because families have a tendency not to push their children as hard as the physical therapist would in the office.
Well, I think that we've kind of covered most everything, unless there are additional questions. Please look in the chat to make sure that you signed in, and also for the CME availability. Finally, again, a big thank you to Dr. Music for going ahead and bringing a case forward. We look forward to everybody involved, whether you're on the EMS side, the nursing side, the doc side. If you have a case that you have concerns, please go ahead and send it to either Catherine, Sarah, or I. And we will go ahead and bring those forward. I believe our next session next month will be on pediatric C-spine injuries. And then I think we're gonna do, I've got to remember the order. I think then it'll be abdominal trauma, and then I believe seizures, I think is the next one after that. So looking forward to having people continue to join and being involved. And if there is any topic that you specifically want brought up, please let us know.
Jeff, Dr. Clement has a hand up.
Oh, yeah, Jason, what's up?
Hey guys. This is Jason Clement and Zuni. Can you hear me?
Now we can.
Okay. This is Jason Clement and Zuni. I was just going to point out that one of the things that can make it hard to get a second opinion, either at the time of initial fracture or later, is difficulty getting the x-rays sent over to either you guys or to Ortho. And I just wanted to draw people's attention to a couple options. One is doing child ready, just so that you can show you guys on our screen kind of what the x-rays look like, or using the PALS line to do Tiger Connect, where you can send snapshots to a specialist at UNM. Those are both workarounds that are far easier for me to do than to try to electronically transmit to the UNM system a patient's x-rays.
Jason, thanks for bringing that up. Yeah, I mean, I think I am so thankful that the Tiger Tech system at UNM finally exists so that we can safely send, pictures and video on our cameras. Same thing for possible seizure activity. I've had people send me images that way. But otherwise, yeah, utilizing our telemedicine machines, we're always happy to look at the x-rays from other facilities as well. Thanks for bringing that up.
And sometimes it's just nice to bounce something off another provider. So it doesn't even have to be anything that you're necessarily horribly concerned about, but just want to, talk it through with someone.
I did want to mention that there are the CE links in, and we do have CEs available for nursing and physicians through one link, and for EMS providers in a separate link. So please be sure to go in and sign up for your CEs. Thank you guys for all of your participation.
Thanks, everybody. We'll stay on for a couple of minutes to answer any questions if anybody has them.
Thank you.
I'm going to stop recording now.